So the negative effects of contraceptives have been well known for quite some time, and there's the immediate things of the weight gain and the low mood and the loss of libido, and a lot of people that I would see would have reported that and say they didn't find that contraception agreed with them. Well, from a pure medical point of view, the question has to be asked because it's invasive, it's expensive, there are health consequences. Is there any other way we can solve this?
Contraceptives are regarded as the standard answer for family planning, as well as various health issues like painful or irregular periods, and IVF is regarded as the standard answer for infertility. But with more and more evidence coming to light on the harmful effects these have on women's health, as well as the serious ethical considerations connected to these, many people are looking for an alternative. The good news is that there is an alternative in fertility awareness-based methods, which are scientific, ethical, and healthy. Here to discuss this with me is Dr. Phil Boyle, the president of the International Institute for Restorative Reproductive Medicine, as well as the developer of NeoFertility, a fertility awareness-based method. He has his own clinic in Ireland and has helped over 3,500 couples who previously struggled with infertility, repeated miscarriages, and unsuccessful IVF procedures. He is here in Budapest now and has spoken at the Endocrinologist Congress. So Dr. Boyle, thank you so much for coming on the show today.
Thanks for having me, Sherry.
So as I mentioned in the introduction, there has really been quite an explosion in recent years of the really harmful effect these contraceptives have on women, and particularly hormonal contraceptives. And just to mention a few examples, the WHO classified it as a group 1 carcinogen, in particular the pill, and also Oxford University researchers recently discovered that actually there's a huge increase in breast cancer risk for those taking any form of hormonal contraception. And I can really say that when, for example, I myself was at a workshop for FABM, fertility awareness-based method, the class was really quite filled with women who had all these personal experiences of these really, really damaging effects these contraceptives have had on their health. So I'm wondering that before your patients came to you, I'm sure many of them were also on various contraceptives. Did they also report back to you on any similar negative effects?
So the negative effects of contraceptives have been well known for quite some time, and there's the immediate things of the weight gain and the low mood and the loss of libido, and a lot of people that I would see would have reported that and say they didn't find that contraception agreed with them. But in terms of more serious adverse effects, it's more nuisance adverse effects I would have observed. So it'd be very hard to observe things on a population incidence of breast cancer or thromboembolism or these more serious risks. So it's more the nuisance effects, and a lot of people said, well, they didn't like them. But others would say, well, they didn't notice any obvious adverse effects, but they would have been on it year after year after year, and then the decision to have a family is put off much longer than it might otherwise be. And all of a sudden, they wake up in their mid-30s and go, hang on, don't we want to have a baby at some stage? Whereas if they're not using contraception, they ask these questions quicker. So I think that's one of the problems I would see, is that it gives in too long a period of time of actually not being open to conceiving. And one of the key things for us is start young and you're more likely to have a baby. If you leave it too late, you're less likely to have a baby.
And you know, it's really interesting to also note that actually with these fertility awareness-based methods, there's also the green movement has kind of got on board, because obviously there is a lot of hormones going into our water system as a result of this, which is not a very good idea. So that's also been nice to see that people have become more aware of this as well. And obviously for us on this pro-life show, it's also very concerning the so-called abortifacient mechanism of both IUDs, copper, hormonal, and actually all forms of hormonal contraception. And this is something that very few people know about. They think it prevents a new life from coming into existence, but there is this so-called backup mechanism, along with the other mechanisms that obviously prevent new life from coming into existence. So could you tell us about what this exactly is?
Sure. So this is quite confusing because through my medical training, I wasn't really aware that hormonal contraception could work at least some of the time after fertilization occurs. So that's not really very explicit, even for doctors in our training. And you have to look very, very closely at it. So the terminology that's used is that, first of all, most women, they won't ovulate. But then backup mechanisms are this contraceptive pill thickens cervical mucus. And the third mechanism is it renders the endometrium hostile to implantation. So it thins the endometrium so that if fertilization does occur, an embryo is far less likely to implant. But even with those mechanisms at play, there's still a breakthrough pregnancy rate for women who are on the pill, so it's not a guarantee of prevention of pregnancy. The biggest question then is, well, hold on a second, that's a new life that's happened if it prevents an embryo from implanting. And while a lot of people are comfortable using a contraceptive to prevent fertilization, many people are uncomfortable if they recognize, you mean sometimes I will ovulate, sometimes there will be fertilization, and the embryo can't implant because of the medications I've taken, and I'm losing an embryo for how many cycles per month, or per year rather. So it's a big concern to people, and a colleague who's a friend of mine, Professor Joe Stanford, published a really good paper on this, and he said that women have the right to be informed about post-fertilization effects of hormonal contraception because most women aren't informed. And admit, well, we don't know, does this happen 2% of the time or 60% of the time, because that's the range, because the data is not known. So we have a best estimate, and estimates are that wide, between 2% or 60% of the time this happens. But whatever the percent is, we can admit, well, we don't know, but this mechanism is at play at least some of the time, and maybe you would like to be aware of that if this is your choice for family planning.
I think, that many people will be surprised, because then it seems rather a deceptive terminology to call it, contraception. And I think it really goes back to, that redefining of pregnancy that happened. I know that specifically in the US it was 1960s, contraceptives came on the market, and then, oh, surprise, 1965, how convenient, American College of Obstetricians and Gynecologists decides to change the definition of pregnancy from fertilization to implantation, which is really astonishing because we do have scientific consensus on when life begins. Even recently, the University of Chicago had a survey and thousands of biologists were asked. Most of them were actually pro-choice, and 95% of them said life does begin at fertilization. So it really seems to be, it is, right, in really just a contrast to this change in definitions, which is really dishonest, I think, and really harmful, I think, to women and obviously these children. But as I mentioned, the good news is that we do have an alternative which is healthy, which is scientific, which is ethical in these so-called fertility awareness-based methods. So what are they, and what are the different types of them?
So fertility awareness-based methods started out, the terminology used to be natural family planning, And the original form of natural family planning was calendar rhythm, where you implement a calculation based on calendar to estimate when you think you're likely to be ovulating without paying attention to your biology at all. And even calendar rhythm would be effective 80% of the time, but when you really want to avoid getting pregnant, 20% pregnancy rate is way too high. So with further advances in science, different methods developed. Probably the original one was the Billings ovulation method, where it was discovered that just before a woman ovulates, you can identify biological markers, in particular cervical mucus, that allows the couple to identify the window of fertility is open. And if you combine calendar combined with cervical mucus observations, then the reliability for identifying the fertile window got stronger. You add a further layer to that, and then you've got the symptothermal method, where symptoms looks for the cervical mucus, thermal looks for temperature shift. So after ovulation passes, you also get a rise in your temperature. So symptoms of mucus, temperature rise, and then a third one is urinary hormone assessment. So in recent times, with advances in technology, we're able to identify urinary estrogen, urinary LH, and urinary progesterone, and we can see the rise and fall of the hormones. And that, combined with the other techniques, allows us to be very precise to say, there's your window of fertility. We are super confident and really able to identify this, to the extent I had somebody who had a serious medical reason to avoid pregnancy. She didn't want to use hormonal contraception for moral reasons. And she said, I'm prepared to abstain for the rest of my life if I need to. I say, well, look, if you track your cycle, you pick your day of ovulation, you get a temperature rise, and you measure urinary progesterone, I guarantee you absolutely, definitely will not get pregnant with that. And if you restrict intercourse to the post-ovulation phase. So it's super reliable, more reliable than hormonal contraception. Now that situation requires more abstinence for what I refer to as a relaxed avoider, where it's not the end of the world if they get pregnant. Then before they ovulate, they can use some of those days as well, but it's not as reliable as post-ovulation. So depending on what kind of a couple you have, do they have a medically serious reason to avoid pregnancy, or are they just spacing? You implement different strategies and get different success rates.
So some of the most famous ones, maybe we could name a few of them. I think NaPro Technology, and of course later I want to talk about NeoFertility as well. So maybe which ones, I mean, I don't know, would you recommend to people who are interested in looking into this?
So every provider believes that their system is the best one out there, and of course I believe ours is the best with NeoFertility, but I think you have to tailor it to the couple. The beauty of the Billings ovulation method is it's really simple. They observe the cervical mucus, they can be very proficient at that, and it'll give a high degree of reliability. So that's purely based on mucus with the Billings ovulation method. NaPro Technology is the scientific techniques that are applied to the Creighton model fertility care system, which is a standardized modification of the Billings ovulation method. So they did further research, but they actually changed the Billings technique a little bit. They made it more complicated in some levels, and they came up with different instructions. But that's what they use, is the Creighton model system. They don't do temperature and they don't do urinary hormone assessment, whereas with our approach with NeoFertility, we use everything. So we go for all of the mucus, we go for temperature, we go for urinary hormones. We put it together on an app at chartneo.com, and then we say to the couple, well, whatever techniques you want to use, you've got a range of options, and you decide whether but our primary indicator would be cervical mucus. It's very simple, very reliable, and we'd say let that be your foundation, and then build on it with temperature or urinary assessment if you want.
So was that one of the primary motivators for you to develop NeoFertility, is that you saw that there is, a way to make this even more reliable, or what motivated you? What did you see that led you to this?
My motivation was more for fertility treatment. So most of what I do is to treat couples with women's health and fertility issues. And a challenge we have is being able to confidently identify the window of fertility and also record the other negative biomarkers. If she's got abnormal bleeding, a short luteal phase, late ovulation, premenstrual symptoms, painful periods. On our app, we document all of these things in a very clear and simple way. So we wanted an app that would record this data in a simple, reliable way, and that was my driver for it. But a very useful component of that is it's super reliable for family planning as well. And we have not yet conducted the research on the reliability of our app for fertility awareness for family planning, but we're standing on the shoulders of giants in the world of symptothermal, Billings ovulation, Creighton model, and we're using all of their research behind what we do so that we know it's going to be reliable. We just have to demonstrate that scientifically now.
Yes, and you mentioned, the issue of painful periods, irregular cycles, and also particularly comes to mind a gynecologist I was speaking to who was saying, that, okay, we don't need hormonal contraception, but what about if you have endometriosis, very advanced, she saw this as really the only option. So all of these issues, which, hormonal birth control is the standard answer, are there other options available to this within fertility awareness-based methods?
Yeah, so what we do is we implement a multifactorial restorative approach. So we work with restorative reproductive medicine, and our thinking is if you have pathology, if you're ill, if you have painful periods, there has to be a reason for that. Now, endometriosis is where the endometrium, the inner lining of the womb, is outside of the uterus in a place where it shouldn't be, and that causes inflammation and pain. The best treatment for that is actually surgery. And if you have the properly trained surgeon to operate and surgically remove the endometriosis, then you're drug-free. You don't need any more medications. And this should be recommended to women in their teens and early 20s if their painful periods are significant and debilitating, rather than medicate them for the next 20 years. Why don't you get to the root cause and get rid of the offending endometrium that's in a place where it shouldn't be? And the hope is that that would preserve her future fertility, because the recurrence rate of endometriosis is very low if it's properly treated surgically.
And very much when women chart, doctors are able to then maybe pick up on certain signs earlier than if they didn't have this data. So what kind of diagnosis can you make based upon this information? What kind of further tests and what kind of resources are available to treat these issues?
So the beauty of this is if a woman is using this for women's health and she's tracking her cycle and she's recording her fertility pattern just purely out of interest, she can document that her periods are very painful, and straight away that's alerting us there's a significant chance this could be endometriosis, and if we go for early medical intervention we could really help. We have some good medications that can resolve that first, and if the medications don't work then the surgical option is very strong. But the other thing then is when they reach the point where they're open to the possibility they may want to become pregnant, the advantage of this approach is we consider that infertility is a problem even before you attempt conception. So this is a radical departure from what current practice is. Current practice is you don't have a fertility problem unless you've been trying for at least 1 year. And we would say, well, look, we can see an abnormal, unhealthy pattern. This tells us you are at risk. You're not definitively infertile, but you'll experience on a population basis, it's going to be harder to get pregnant. And if you do become pregnant, there's going to be more miscarriages and premature delivery and adverse pregnancy outcome. So we would say preemptively, we intervene, we restore your health, you feel better, we restore a normal pattern to your cycle, we get rid of period pain, abnormal bleeding, regulate your cycle, you feel and function better, the negative symptoms are gone, and our view is healthy women are fertile women. Whereas hormonal contraception takes the view that fertility, it's being treated as if it's a disease that needs to be medicated. And we go, no, fertility is health. Live in harmony with your health, don't suppress it. And it's a different philosophical approach to one's fertility. So the advantage of being able to say to somebody that we can preemptively optimize your cycle before you even try to become pregnant, that becomes especially useful when you're in your late 30s, you're later getting married, you're wondering, do you have a fertility problem? You can intervene and correct that cycle very, very quickly instead of having somebody wait. And equally those who have 2, 3 and more miscarriages, you've intervened before they have one. So it's a beautiful advancement in this area of medicine.
Absolutely. And you mentioned, I think, some of the accuracy early on, but I would be interested that do we have any data to compare in general? I mean, obviously there are different types of contraceptives, and but in general, how could we compare the fertility awareness-based methods to, you know, contraceptives, including condoms, etc.?
So there's a group called Facts, Facts About Fertility, who are based in the United States, and they published a study comparing success rates of the various different fertility awareness-based methods compared to contraceptive methods. And they compare very favorably, but they also admit we don't have high-quality studies to definitively show to the critics that fertility awareness-based methods are as reliable as we claim. So there's a lack of good published data to prove that fertility awareness-based methods are truly that good. We know from our clinical experience and common sense, we know how to identify the window of fertility, and when people are highly motivated, the most effective method that's been documented is a symptothermal method, where you look at the symptoms, you look at the temperature, and these were people who were very, very motivated to avoid pregnancy, and they did not have intercourse at the fertile time, and they proved that was highly, highly reliable, 98% effective, the same as the birth control pill. So one of the key things a lot of these studies don't take into account is the motivation of couples. And it's counted as a method failure if they start out at the beginning of the study and say, well, we don't want to have a baby. They knowingly change their mind. They've intercourse on a recognized fertile day. They get pregnant, and that's counted as, terrible term, failure because they had a pregnancy. Whereas they knowingly used those days. So the studies, the way they were designed, didn't take that into account.
Yes. And, you know, we will be getting into this in the next section of the interview about how, of course, you know, we can use these methods to both avoid but also to achieve pregnancy. But before we do that, you know, we have to address so-called the elephant in the room, in that there's so much going for these methods, as we talked about now, but I mean, let's be honest, it does require a very different attitude towards sex. And it's very countercultural in some way. So what would be kind of, you know, your response or some of your experience with your patients, that how have, you know, they responded to this transition? What was it like for them?
So the attitude, there's different kinds of patients that I would see. And I would see people coming from a very Catholic perspective who have a strong moral compass to say they want to live consistent with their faith, which means they can't use hormonal contraception and they want to practice periodic abstinence. And they would admit it's not easy. And it feels like anytime they want to be physically intimate, they're at their fertile time. And if they choose to be intimate, there's a consequence to that. And sometimes they're at that period of their life where they say, I don't think we're open to having another child just yet. So it's very difficult for the couple to practice that periodic abstinence. But all of a sudden then, the nature of love is such that I love you so much, I'm prepared to deny myself pleasure for your good. And the love grows through that, whereas and then you're used to practicing periodic abstinence and self-control and thinking of the other person, and that fosters the growth of love. So what starts out as a real difficulty for a couple turns out to a deeper expression of their love, and their intimacy and their love grows. So then when they truly can be together, it enriches that experience for them. And the interesting thing is, although their availability is reduced, they have a higher frequency of intercourse compared to couples that are using contraception, because when you're on the pill, it drops your libido, it reduces your mood, and then you feel that you don't have the same frequency of intercourse as couples using natural methods.
Gosh, incredible.
So it's a funny thing that happens psychologically. And it's the couples who experience the benefits of this periodic abstinence who are the greatest promoters of it, and they admit it is hard, it does have its challenges, and you do need to draw on your faith a little bit to ask for the grace to accept that, and it's difficult because then The other group of couples that I have are those that would choose to use condoms during the fertile time, and they don't seem to get those benefits. So one of the key things is you sacrifice yourself for the sake of the other, and love seems to grow through that.
So I'd like to go really into our second main topic, which is all around the issue of infertility and how we can respond to it, because it's really astonishing the rates at which this is a problem at the moment. I just saw a statistic from the WHO saying that 1 in 6 people are affected by this. And of course, if somebody does want to have children or more children, this is a very, very painful thing to go through. And really, it is with great compassion that we speak about this issue. But of course, it is always the question of how we respond to any given issue, right? And I think, first of all, I'd like to just ask you to really outline, what is IVF and how do they achieve these pregnancies?
So IVF stands for in vitro fertilization, which literally means fertilizing in glass. But fertilization actually happens in a petri dish. And I was researching it recently and I was surprised to find out the first successful in vitro fertilization in an animal was in 1959. And it was nearly 20 years later before that was conducted in humans successfully. But basically what it involves is it was designed for situations where the fallopian tubes are blocked and it's not possible to get fertilization ordinarily. So for the first successful IVF in Louise Brown, her mother had bilateral blocked fallopian tubes, and what they did was they extract an egg from the ovary. The egg is put in a petri dish, and then sperm are added to the petri dish to achieve fertilization. The embryo grows and develops in the petri dish, and then when it's anywhere from 3 to 5 days old, it's transferred back into the uterus in the hope that it may implant. So that's broadly what the technique is. It's changed over the years. So the first IVF cycles, the success rate was 2%. They treated 100 women and 2 women had a baby from the process. And then they found if they stimulate the ovaries to produce more follicles, then you've got more eggs that are available, more eggs will fertilize, you've got more embryos, and then you could pick the best of those embryos to put back. And at one time they were putting back 2, 3, 4 embryos and getting multiple pregnancies. So current practice now is single embryo transfer. And the preferred technique for most in vitro fertilization centers is you want to get about 10 or 12 eggs, so you produce 1 year's supply of eggs in one single cycle. And the woman takes strong injections to cause her to produce multiple follicles and multiple eggs. Those eggs are retrieved from her ovaries and then they're fertilized. So you'll have anywhere from 10 to 12 eggs fertilized. Out of those, you'll have about maybe 8 embryos, and you try to decide through various different techniques which embryo do we think is the best quality to put back in the hope we may get a successful pregnancy. So to my mind, this is where it becomes quite problematic, because for every baby that is born, at least 5 embryos perish in the process. Wow. So while every life is beautiful, no matter how conception occurs, and everyone is of infinite value, you say, well, because you're beautiful and you're in infinite value, is it good that we'd so many people like you at an early stage of development that were lost through the process? 5 of your siblings perished in the process. Or if they didn't perish, they were deemed, well, it's surplus to requirements, so they're kept in the deep freeze and they're never used. So if you get success with in vitro and you decide you have excess embryos that you don't need, you have all this problem of excess embryos as well. So in a very real way, a human person at the earliest stages of its existence becomes treated like a product or a thing, instead of being valued for who you are at the earliest stages. You're more of a thing that is subject to quality control, testing, and you have a best before date. So if you're not used by a certain date, you're discarded. And we have to have serious conversations about, well, what is an embryo? Is an embryo really a person? And explore these questions in a deeper level, and how can a unique human individual not be a person, would be my view on it. And if it is a person, is this a good way to treat people, even though we have a very good end in mind and we want to help people with a fertility problem? Is this a good way to do it?
And what you said about, then testing these embryos and seeing which one should be transferred, I mean, that is a eugenic practice, right? That we hear about, these embryos who are then diagnosed to have some kind of problem, and then they get discarded or donated to research, so-called, right? Which is, again, very grotesque, right? Doing that on a human being. And so that's really disturbing. And, also I was looking at these statistics in Britain from 2013, between 1996 and 2006, they had 122,000 children who were born via IVF procedure, but then 3.8 million embryos were created during that time. So, I mean, the difference between those two numbers is truly astonishing and just really disturbing. That, what happens to those embryos, and even if, some people say, well, I'm just going to have one embryo created, it's still purposefully allowing that person to be in a place where they wouldn't normally be, which is not the safe place for them to be. So it's very, very problematic from many points of view. And I would also highly recommend our viewers to check out the interview with Dr. Kolb that I did, as we were talking also about the aspect of selective reductions in these IVF situations, where the doctor will say, well, you're pregnant with 2, 3 or more children, so this is risky, we should reduce, and which means taking the life of one of these children. And she really outlined what that means and how unnecessary it really is. So really, really concerning on multiple fronts. But again, we do have a positive alternative, because we didn't touch on this, but there are health risks involved with IVF as well. There was this really interesting article I was reading where this former IVF doctor was really outlining all of these incredible risks, saying, 2 times the risk of ectopic pregnancy, more miscarriages, preterm deliveries, the large dosages of estrogen causing potentially higher risk for breast and ovarian cancer. I mean, it goes on and on, even larger chance of some kind of abnormality for the child. I mean, this is, really risky, even if you put aside all these ethical considerations. So, we do have a better alternative.
Yeah,
and what is it?
Well, from a pure medical point of view, the question has to be asked, because it's invasive, it's expensive, there are health consequences. Is there any other way we can solve this? And there's only a tiny number of people who go for in vitro fertilization who, inverted commas, need it because both of the tubes are blocked or the sperm count is very, very low. So if it's below the 1 million mark for the sperm count, then achieving natural conception is significantly lower, or if both tubes are blocked. But apart from that tiny little group, which is like less than 5% of those who do in vitro fertilization, 95% of people can get there another way. And that's what we tend to do with restorative reproductive medicine. Now, I've been practicing this area for 25 years, and we have evolved and improved our techniques over time. And for 2019, we've looked at our data, and we've shown that we can get a live birth rate on a population basis of 40%. And this is for an average female age of 36. 20% of our couples had tried and failed in vitro fertilization, and it was a difficult group that we had treated. So that 40% live birth rate that we achieved, that contrasts with in vitro fertilization on a population basis. It's only 24% live birth rate. So we're a significantly higher chance of being able to achieve success. And so the point is, If you have no moral compass and you just want to have a baby, choose restorative reproductive medicine. And the catch with it is, well, it can take a little bit longer, but it's less invasive, it's less expensive, you're not exposing yourself to health risks, we don't hyperstimulate your cycle, we normal stimulate, we balance, your health improves, your communication as a couple improves, and your fertility will be better compared to somebody doing in vitro fertilization. Plus, we have a lower incidence of multiple pregnancies. Our multiple pregnancy rate is 2.5%, and it's 6% for in vitro fertilization. And we don't have premature deliveries or low birth weight. So we win on multiple levels when you contrast restorative reproductive medicine. And we go back to the idea that good ethics is good medicine. And our view would be, if you do what's ethically sound, you're going to get what's medically sound as well.
So what does this process look like when someone, comes to you saying, we've been trying for however long, we don't know what's going on? What is it that, you start looking for in both on the male and the female side?
So the first thing I say to people on day one is we get their history and get all the information. And the very first thing I say is, today is the day you stop trying to get pregnant. And you can see that they come in pretty tense, and then they go, oh. And when the pressure is off, pregnancy comes in. So that's the very first step. So when you're pumped full of adrenaline, pressure, stress, intensity, and it matters so much, you have to try and break that. And then the next thing I say is, hopefully by this time next year, we may have a successful pregnancy on the way. So you manage their expectations. The efficiency of fertility is, it's normal to take a year. So once we get that context right, then we say, now let's see if we can understand where the problems lie. And the first thing we want them to do is cycle tracking with our fertility app, so we can see all these parameters, the bleeding pattern, the mucus, the timing of ovulation, the length of the luteal phase. And then we want to check your hormones in a very detailed, specific way that is different than what's currently being practiced. So we have a new concept where the majority of women coming to us are ovulating, and our question isn't, are you ovulating? Rather, when you ovulate, 7 days after that, what is the quality of your ovulation? So it's a new concept, and it allows us to detect subtle hormone deficiencies that escape detection otherwise. And when we identify these deficiencies and we restore a balance, we double check by ultrasound to verify that we see she's ovulating. So our context is, I want you to feel good, I want your fertility pattern to look good, I want to see you ovulate by ultrasound. We want to verify that your hormones are balanced, and when all these things are right, then in a pleasant, relaxed enjoyment, remember, a baby is more a fruit of your love, not your labour. Enjoy being together because you want to be, not because a chart says you have to. And then on the male side, we like to get a detailed assessment of the male factor, and if we identify there's a male factor contributing, for both of them, we change their diet, we put them on supplements, and we give them whatever medications we think they need to improve both male and female fertility. We involve the guys in the cycle tracking process. So on the app, they use the same email, same password. She's documenting her observations. He's putting in the medications, the blood results, the days of intercourse. And between the two of them, they build up a profile of what is essentially their combined fertility pattern. And what's interesting, I presented at a conference recently, we had couples with male factor infertility where they were told they needed in vitro fertilization because the numbers were too low. But we said, well, they are a bit low, but we can work with this. It's above the 1 million mark. And although one couple in particular, his count stayed exactly the same and it didn't improve, we enhanced the female side, and that was able to compensate for a persistent suboptimal male factor as well. So one of the best things we can do for male factor is to optimize the female factor, and 70% of couples with male factor have additional hidden female factors that often weren't previously identified or treated.
And, I think it's sort of that it does seem like an incredible irony that, IVF is presented as this, great advance in science, yet it is these fertility awareness-based methods that are actually using the tools of modern medicine to treat all of these issues that are ongoing, that many times are not investigated for people who go for the IVF route. And, I'm wondering what can be actually the effect on these women who, for years, they, on our previous topic, say they have these painful periods, but instead of looking into it, here's some hormonal contraception. You can't get pregnant, well, go to IVF. And instead of looking at what the issue is, they just, get these solutions. So what is the effect on the body of living for maybe a decade with these untreated issues inside of you? Like, what could be some potential outcomes here?
Well, I've so many people who have multiple failed IVF and they'd previous undetected, undiagnosed endometriosis, and they never even go for a laparoscopy to deal with that. And the truth is, if you have a laparoscopy and you remove the endometriosis, then you get relief of symptoms, but it also improves your fertility outcomes for restorative fertility treatment as well as for IVF. So it's also incumbent upon IVF clinics to find the root cause, especially endometriosis, and get rid of it. And our hope is, well, if you do that, then you shouldn't even need IVF in the first place. But persistent inflammation in a place where it shouldn't be, sometimes it infiltrates the bowel, and then you get bowel-related symptoms, bladder-related symptoms. And we have a surgeon in Ireland who's very active in going after the endometriosis that is affecting the bowel. And his concern is, if that's left undetected and untreated, then you should most likely have a higher risk of bowel cancer into the future if you don't deal with that. So he's now of the view we should proactively go after that to protect their future health as well. So it's a controversial area, and we don't know for sure if it's right, but that's the view that he's taking, and it makes sense. But the women who have that surgery experience incredible relief, and they say it's worth it for symptom relief, if nothing else.
And also, is there an effect for maybe a benefit of treating these issues before pregnancy, for specifically maybe for the health of the child or that pregnancy itself?
Yeah, we have a radical new concept that if we correct everything, then the baby is going to be healthier as well. And there's one medication we give that has a strong anti-inflammatory effect, and we boost endorphins with this treatment of low-dose naltrexone, especially for women with endometriosis. They feel calmer, they've less pain, there's less anxiety, and this is a very favourable physiological state for the mother during pregnancy. And our hope is that it'll positively influence a thing called epigenetics, so that even if she has a genetic predisposition for endometriosis, then if the mother has endometriosis and she's on this treatment, that her daughter may be less likely to express that if she's on medications during pregnancy to control for those symptoms. So it's called, you reduce methylation and you positively influence the epigenetics so that endometriosis isn't as severe in the next generation.
And, I think another thing that people don't think about is that we're so focused on that one pregnancy and that moment, but we don't think that, okay, well, what about the next one? Maybe the person would actually like to have 2 or 3 children, and if they treat these issues, then they could go on to have multiple children, right? And it's sort of restored things back to its normal functioning, right? So I think that's also another positive issue that doesn't get highlighted enough.
Oh yeah, hugely. The potential for repeat pregnancies is very strong. Once you've dealt with the root problem, then you implement the same restorative strategies repeatedly and you can have repeated successful pregnancies. Sometimes endometriosis will come back. So somebody who just had her 5th baby with us, and she had endometriosis, it was dealt with, we got 4 beautiful pregnancies, a little bit more ambitious than most. They decided they really would like a 5th. And we did 10 months of treatment and we just could not get it to work. And with our multifactorial restorative strategy, we said there has to be a reason, this should be happening. And we made the decision to go for repeat surgery, found the endometriosis came back, had it surgically removed, and she's just recently delivered her 5th baby, as it turns out. But that's going back to the restorative principles. If it's not happening, then you continually ask why, and fix all the things you can find, and hope to get repeat successes.
Yes, and I believe that earlier you mentioned the question of miscarriages and preterm births, and I'm wondering that, if you are, say, monitoring via these, chartings that the woman's pregnancy maybe from an even earlier time than would be, normal usually. Are you maybe able to pick up on any, factors that could cause a miscarriage, but you're able to intervene or, in any way kind of reduce those early miscarriages?
Yeah, it's a good question because we've recently come up with a new treatment strategy specifically because of that. And we've identified that low estrogen levels will give you a higher incidence of miscarriage. So for the last 11 years, we've been analysing and treating this, and we've come up with a new treatment strategy that in fact any fertility clinic can use. And it's a treatment with DHEA to treat estrogen deficiency, restore normal estrogen levels, and dramatically reduce the incidence of miscarriage. So this evolved because over the years, there were some patients that I was treating, I could see their estrogen levels were way too low, and we would continue to get miscarriages. And then eventually our practice evolved that we found a way to solve this, and now we have fewer miscarriages because of that treatment. We're on the verge of publishing our data on this to encourage other doctors to do the same.
That's incredible. And, I'm wondering some of maybe the more concrete comparisons we can say to people, because, you mentioned that it's, cheaper, and maybe that also the success rates, that what are some maybe concrete numbers that we can give with success rates, costs, and also like the difference between how long each one takes?
So this is a delicate question for us at the moment because in Ireland, the Irish government have chosen to provide funding selectively for in vitro fertilisation, and they won't fund us at the moment. So we're hopefully going to have dialogue with our government and present our data to them. So these figures are fresh for me at the top of my head. And where it gets a little bit confusing is that the in vitro fertilisation clinics, they quote clinical pregnancy per embryo transfer. So it's a confusing kind of a figure, and what people need to know is if I start a cycle of IVF, what are the chances I'm going to have a baby? That number is 24%. It's really, really low. So the clinics, they keep quoting numbers that are much higher than that because they quote pregnancies only for those people who get to embryo transfer. So it looks like they're 35-40% successful when they're actually down at 24%. So I would say it's dishonest. And it's not clear information, and we need to be very clear for people what the data is. When we look at our data and our actual numbers for live birth, we're 40% on a population basis. So we're significantly higher. And then you look at the cost. We're less expensive compared to in vitro fertilisation. So we call it the €1 million challenge. So if you're the government and you've got €1 million and say, we have a problem with couples who have infertility, we want to help our infertile couples. And the advice they've received is in vitro fertilisation is your solution. Well, €1 million in Ireland at €5,000 for an IVF cycle will allow you to treat 200 couples. So for your €1 million, treating 200 couples, you get 48 babies. You give that €1 million to Restorative Reproductive Medicine with NeoFertility, we can treat 500 couples. It's €2,000 a go, so we got 500 couples we can treat. The number of babies we get from that is 200.
Wow.
So your €1 million can give you 200 babies or it can give you 48 babies. I wonder which one will I choose? So, but in fairness, in defence of our government and their advisors, they have not received the information from us in a way they can see and understand and analyse. And we're more than happy to conduct a prospective clinical trial where we'd say all we're asking for is a level playing field. Fund us as well, compare the outcomes of our approach, allow people to choose this, and then look at the outcomes in an objective way and make up your own mind. How do you think you should, where do you think the funding should go? And I don't believe that IVF is going to come close to our data.
Absolutely incredible. And, for any of our viewers who, have been really, their interest has been piqued, what, websites would you recommend them to maybe find more information, opportunities for doctors practicing in this area?
So the websites, it depends on the country that you're in. So the International Institute for Restorative Reproductive Medicine, so that's an international group that would represent all of the places that provide restorative reproductive medicine. Our website is neofertility.ie, and then if you're going to be showing it in Hungary or There's the Hungarian website that I don't even know.
Yes,
so
we will,
include
it, yes, in the description.
Yeah.
Yes, absolutely. So thank you so much for this really incredibly informative and really inspiring conversation, because it is a positive message that there is a better journey, a better path for your family planning, for infertility issues, and so this is a really positive message that we have, and thank you so much for all that you do in this area and for coming on the show today.
You're very welcome. Thank you.